Good afternoon, everyone. Welcome to the Assembly of Osteopathic Graduate Medical Education, the AOGME webinar series. We're pleased to have joining us for this CME Development Series webinar on state-level collaboration for GME development. My name is Dr. Sherry Turner. I'm the former Vice Chair of AOGME's Council of GME Leaders and the current AOGME Board Secretary. I'll help facilitate this webinar. Before we get started, I'd like to review some housekeeping notes. The webinar is being recorded. The recording will be posted on AOGME's webpage within 7 calendar days of this presentation. All webinar participants are in listening mode only. If you experience technical issues during the webinar, please use the chat feature and we will assist you. If you have questions for the presenters during the webinar, feel free to submit them in the question answer feature at any time. If time permits at the end of the webinar, the speakers will respond to your questions. I'm excited to announce that osteopathic physicians can earn up to 1 credit hour of AOA Category 1A CME credit for attending this webinar live. To obtain that credit, you can complete the post-webinar evaluation survey, as well as email aogme@aacom.org to be sent the attestation form. I will now briefly introduce our presenters. Dr. Cliff Knight is a family physician with extensive experience in medical education and healthcare leadership. He currently serves as the Assistant Dean of Graduate Medical Education at Marian University, Tom and Julie Wood College of Osteopathic Medicine, where he focuses on supporting clinical partnerships and developing and expanding GME programs, particularly in the Indiana rural communities. From 2020 to 2023, he held the role of Assistant Dean of Clinical Affairs at MUWCOM. Since 2020, Dr. Knight has represented MUWCOM on the Indiana Graduate Medical Education Board. He also serves on the Board of Directors for the Indiana Academy of Family Physicians and chairs its Commission on Legislation and is an alternative trustee for the Indiana State Medical Association. Additionally, he's a board member for the Indianapolis Medical Society and Ascension St. Vincent's Health in Indianapolis. Our second presenter, Dr. Russell Myers, actually he'll be our first presenter because he needs to leave a little early today, is a family physician with over a quarter century of experience in graduate medical education. He taught with CHC on programs where he led the program as the director for 15 years and served as the DIO. During this time, the residency increased from 18 to 30 residents, received 2 HRSA Teaching Health Center grants, and developed a novel 3-year integrated rural track training. The program was also a leader in developing integrated behavioral health and dramatically increased the diversity of its faculty. He currently serves as Associate Dean of Graduate Medical Education at Pacific Northwestern University College of Osteopathic Medicine and is a professor of family medicine there, as well as clinical professor at the University of Washington School of Medicine. He consults with HRSA, THC, GME, Technical Assistance Program, and the WHAMI Family Medicine Residency Network, building new programs and assisting existing programs. Thank you to both Dr. Knight and Meyer for joining us today and sharing your expertise. With that, I will turn it over. Dr. Meyer.
Thanks very much, Dr. Turner. We have several objectives that I hope Dr. Knight and I cover adequately for you today, and I think we will, and you can read them yourselves. Next slide, please, Ramenta. You know that's our order for today. So I'm going to talk about our family medicine residency network because I think it's illustrative of many different ways to solve a similar problem and also really bring home the idea that there is no one size fits all. You've lots of you have heard the analogy of you've seen one, you've seen one. And I think that applies to state-based GME. So we are a network of family medicine residency programs here in the Northwest. Um, every state has a different approach, and one of our states is in development. So this could be you too if you're not already doing this. So I'll go through state by state in an order of the acronym, WWAMI, the Washington, Wyoming, Alaska, Montana, and Idaho, um, and then summarize. So next slide, please. So Washington was the first state with residencies in the region. Once upon a time, there was a WA. And the WA was at the very beginning 4 programs in Washington state. And they got together, and on the left-hand side of the slide here, you'll see sort of the order of major landmarks in our development over time. And like many states, we started with some external foundation funding, and that led to obtaining state support, with growth, a new version of state support. And as the region grew, we realized Washington state couldn't support conscionably the other states with tax revenues in Washington. And so we created a regional revenue account, and so asked the member programs from the other states to pay a set fee, for which they get a whole long list of benefits. And someday we could talk about networks, and I could go into that, but that would be for another talk. In 2015 was really a banner year for this network. In the background, 2 new medical schools opened in Washington State, Pacific Northwest University, and the WSU, Ellison J. Floyd School of Medicine, so a state school and a private not-for-profit osteopathic school. And one of the things that we did in 2015 is we took these different Senate bills, combined them together, and obtained some new funds that really allowed us to do significant residency development. And that's on the right-hand side of the screen. With that funding that we had through 30-ish years, 40-ish years, had done quite a bit of work, and had grown from 4 programs in Washington to about 15 programs in Washington, and a series across the Northwest. But it was really the funding that provided designated startup funds. We hadn't had that historically, that really allowed us to build, especially in rural communities. And because of inflation, we asked for and received some additional money in 2023. Next slide, please. So that state support, there's direct state support that comes to us from what's called the Safety Net Assessment Fund. And you'll see this in many of the examples where there's a Medicaid match. Somebody puts up money, goes to Medicaid, and you get your money plus more back. And the hospitals have been doing that for a while. And the residency programs around the state, we had good data to support this, really serve as a safety net clinic for those hospitals. So they saw the benefit of investing in the residency programs. And the general operating fund basically matched those funds. So that's what's provided us with our primary nest egg to provide a network, which has been critical to the growth, and build, as you can see in Washington's state here. There also are some Medicaid dollars. They are murky. We've tried actually for about 2 years now to find out the current dollar amount that programs are receiving, and due to various administrative changes and changes in the way Medicaid is paid for, through the intermediaries, we haven't been able to find, and Medicaid's not exactly sure what dollars the programs are receiving, but historically it was based on, and still is based on, their CMS cost report. So one of the major problems with that is that if you're a totally THC funded program and your residents don't appear anywhere on the cost report because you may be rotating in a capped hospital, the hospital is not getting any additional funds. But that is a large pot of money. Historically, we've been in the top 10 in states of Medicaid dollars. So those dollars flow to the hospitals to support programs, and that SNAF and GOF fund support the network in a direct capitated system of $20,000 per resident in the state. Next slide, please. So it's interesting in the West, as it is in many geographic areas of the country. So Wyoming made a decision that, and this is a quote directly from folks in Wyoming, so I feel comfortable using it. We don't want no stinking federal dollars. And they started their programs with no CMS support, and have ever since operated off of clinical income and state support. The two hospitals realized once they had residents rotating through, they could claim IME, and they do claim IME, or indirect medical education, which they keep. They do not share any of those funds at this time with those two programs, or with the rural track. And there is no Medicaid support and no CMS support. But if you look across our states, it is Wyoming that, on a per resident basis, medical resident basis, provides the largest support for the residencies. They basically are funding as if they were CMS in a well-funded system. So I think Wyoming's a great example of a state can do this on their own, and they can put a significant dollar resource into the programs, but it then there's a lot of politics every legislative session, every budget year, every 2 years, going through this piece. Next slide, please. So as I noted, Alaska is in development. Briefly, when they have the fewest medical residents per capita in the U.S. and have really been looking to grow GME. And initially, they did have Medicaid and direct state support. The Medicaid dollars were linked to the hospital. And when Providence underwent a reorganization and put all their hospital-based programs into their clinic part of their system, no one was paying attention to those dollars because that had been there at setup, and there'd been a changeover in program director and leadership at the program. So no one was really watching the money at Providence or in the residency, and they lost somewhere north of $1 million of Medicaid support because of the reorganization of the clinics. Working again as a region and looking at where we could really help someone develop state-based support, our larger WWAMI group has held a biannual GME summit. And so we planned and held one in Alaska directly around what the different states are doing for development of GME. And if that background noise is too much, I can repeat that. So we specifically held a summit talking about what different states, not only in the Northwest, but regionally, what they do in Colorado, what they do in New Mexico, some other Western states. And that conference led to a nascent GME council. There's 3 residency programs in early development up there, family medicine, 2 family medicine, 1 ONMM program, and interest in a psychiatry program. There's a little brand new GME, but it's really occurring out of an urban academic medical center based in another state. So it's not quite state-based. Next slide, please. So Idaho and Montana, to finish off our WWAMI acronym, are a really great example of two very different ways to slice the pie. You can see, and I want to thank Rob um, Stanger and Ted Epperly for sharing this information, as I wouldn't have any of this information without my colleagues who have allowed me to share this. So it's really emblematic of our network is that we share information quite freely with one another to help one another get better. So Idaho has a state-based model where it's in the Board of Education, and the membership you see on that left-hand side, and they have quarterly meetings, and they fund around $70,000 per year per resident to programs and have startup funds that are available. The model here is across all specialties, not just family medicine. Montana has it all centered in the hospitals. It's 5 teaching hospitals, 4 residency programs, of which 2 are family medicine. One is internal medicine and a new psychiatry program. They also include all 3 medical schools that are in the state, and the other pieces you see there. So different meeting structure, different membership structure. In Idaho, it is really state tax dollars that support it. In Montana, it is a Medicaid match program that supports it. Next slide, please. So, we started with 6 residency programs in 1975 in 2 states, and we're now up to 5 states, 32 core programs, 10 rural tracks, 34 fellowships, and a whole lot of residents in family medicine across the region. And none of that would have happened without significant state support. Lots of the programs receive teaching health center funding, even more receive CMS funding, classic funding, but we have programs that essentially are totally supported by their hospital along with state support, or as we noted in Wyoming, totally supported by the state with no hospital support, no federal support. So it's a whole different ways of reaching this goal of increasing training. Next slide, please. So there are things that have worked well and things that have not worked well. I noted one of them that's worked well is this growth. And a few years ago, when I was looking at how big the network had grown, I'm going to just mute myself for a moment here. Or are you hearing any background noise? No, great. I'll keep talking. I figured out that we were the largest, our network is the largest GME program west of Minnesota and north of California. So to put that in context, we aren't an academic medical center. We're an affiliated group of programs. The University of Washington, which houses the administrative offices, has 1 program and 1 rural track. These programs are all owned by health centers and hospitals throughout the region and medical systems. And so that you can do this state-based support and grow into something big. But what has worked is that coalition, having that infrastructure piece. varied funding is really key. Any one of these programs in its threats in these last 10, 20 years would have gone under if they hadn't had more than one source of funds. Um, and in states other than Washington, well,
I'm sorry, I think we've got a glitch there for a moment. We'll give him a second and see if he can get back with us. While we're waiting for him, if he gets back in, we wanted, after he finishes his speaking, to take a moment and allow questions, particularly on his section, because he has to make it to the airport after the meeting. I think he's gone out to come back in, so hopefully we'll give him a second to do that. If we have time for that questions, we will. If not, if you'll put your questions in the question and answer or in the chat, we'll see if we can get those back out to you, and the people at AACOM who support us, Aletha and Nala, can see if we can get that disseminated to the people who are here. Thank you for your patience. I give about one more minute, Dr. Knight, and then we'll let you go ahead and start. Well, there,
yeah,
yeah,
I
he's back.
apologize for disappearing for a minute, but I've done this before, so I had my hotspot ready to go. The other piece that uh, hasn't worked well is the support around all specialties. The states that have been most successful, and I really think actually Idaho and Montana are the most successful of our states, have really looked uh, at this from a state perspective, not a medical school perspective, not a specialty perspective, but what types of docs do we need in what parts of the state, and then build towards that. So key pieces that make this work are your taking what's available. You never know what's there, and you won't find out unless you go out and root around. And as you can see, we've across the region, we've used a number of different methods of providing this funding. And it has to be something that works for your state and for your institution. All politics are local. And that honestly is an advantage for GME and state support, because those representatives and senators and office holders who are staff, who have lots of power in this process, they understand what's happening in their community. They know what it's like to wait to get a visit or have a delay in a referral. So I'll stop here and see if there are any questions before I have to step out.
Would anyone like to pose a question in the chat?
Yeah, there's what does the WWAMI Coalition provide to do for the member states beyond meeting to plan and advise? If we've got another hour and a half, maybe two, I could go through that. But very simply, we provide the educational support for programs. So we provide a program director's workshop that's quarterly, an administrator's workshop that's twice a year, a pharmacy workshop, et cetera, et cetera. We have monthly webinars for folks around education. We provide on-site site visits that people can ask at any time, help people with their ACGME applications. We work collaboratively on recruiting for faculty and other issues. So there's quite a bit that the network supports. Far and away, the most valuable is bringing people together to talk about their problems and to share. THC, Randy, THC grants are based on what the feds decide they're going to provide this year or this federal budget cycle. So depending on the amount of money in that cycle and how much, how good your grant proposal looks, they've funded programs from as small as 2 residents per year to as large as 8 to 12 residents per year. So, Catherine, somewhat like a GME technical advisory center, it's really all of the things a DIO and an academic institution or a sponsoring institution should do for a program, but frequently don't. And in many respects, the very most valuable piece is the support group and trust. In our world, you can sometimes get yourself in trouble asking questions, but uh, the, the directors have a very active listserv, and it's those hallway conversations when we get together once a quarter that are very quite valuable. So if there are no other questions, and using Dr. Turner's leadership skills, I'm pausing for a moment. Um, I'd love to turn it over to my colleague and friend, Dr. Cliff Knight.
And Dr. Meyer, thank you so much for your expertise and your contribution today. Enjoy your flight and your time with your family.
Yeah, safe travels, Dr. Meyer. Well, thanks for this opportunity. I'm going to talk a bit about our experience here in Indiana over the last 10 years or so. And I'm going to talk about a strategy that we've used to stimulate GME growth and the results we've had to this point, which I think are pretty remarkable. But now some challenges. We're really at an inflection point 10 years into this. And I'm going to share that with you. And I don't have all the answers. And, that's really what I'm going to share with you is sort of what we're thinking as potential ways to address the challenges that we have right now. So in 2013, Marian University opened our doors here at the College of Osteopathic Medicine. And it was the first new medical school in Indiana in over 100 years. The Indiana University School of Medicine is the largest medical school in the United States, has about 370, between 350, 370 per class. It's a large medical school. It's where I went to medical school, but we needed a second medical school in Indiana that was a bit more focused on primary care. And so in 2013, we opened our doors, and our founding dean, Dr. Paul Evans, really worked with many of the community-based hospitals around the state who were interested in developing GME. To that point, most of the GME, other than some family medicine residencies, most of the GME in Indiana was through the Indiana University School of Medicine. So this was a time where there was a recognition that we needed not only to grow from adding a new medical school, but also to increase GME in the state. And so, recognizing that folks are more likely to practice in the areas where they train, and if they have that experience working in underserved areas, they're more comfortable with that. We really looked to develop a strategy of expanding GME throughout the state of Indiana, and really the bottom bullet point there, the state funding was the opportunity to then look at trying to develop new GME in the state. So I'm going to share that story. So in 2015, the legislature here in Indiana created the Indiana Graduate Medical Education Board. And I've had the pleasure of serving on that board representing our College of Osteopathic Medicine here since 2020. And the board is made up by 10 members appointed by the governor. There's representatives from both Marian as well as the Indiana University School of Medicine, as well as one of the IU School of Medicine regional campuses. IU's model is decentralized, and so there's multiple regional campuses across the state. And then we also have representatives from the Indiana Osteopathic Association, the Indiana State Medical Association, the Indiana Primary Healthcare Association, which is really representative of the FQHCs around the state and other community health centers around the state. And then representative from a teaching hospital, a non-teaching hospital, and then 2 program directors of residency programs. So it's a really robust group, the 10 members on the board. We have some great discussions. But again, the important thing was the state decided that they would, on an annual basis, give some appropriations to this board. And then our job as the board is to figure out what to do with that money to try and stimulate GME growth in Indiana. And so there are 3 different grants that our board can distribute. The first is a discovery grant, and that's really a one-time up to $75,000 to offset the expense of doing a feasibility study or a consultation for developing new GME programs. And so, we try and work with hospitals and FQHCs to identify who's interested in potentially hosting GME in their site. And then they have the opportunity to apply for those grants, and they can develop a pro forma and get a sense of, what would it really take to open GME in their healthcare entity. The second level of grant then is a program development grant, and that's a one-time up to $500,000 spread out over 2 years, and that's really to offset that startup time when, as everybody is likely aware, there's no CMS funding, until your residents are on site, feet on the ground there. And so that $500,000 is available for starting up a GME program to offset some of those expenses like hiring a program director and a program coordinator, and getting other faculty on board. And then the third level is the expansion grant. And that gives up to $45,000 per resident per year to offset then any gap between the cost of educating a resident and the funding of those slots that you may have. And so really what we've found over the 10 years that this has been in existence is now we're at a maturation stage where many of the programs that accessed the discovery grants and then went on to use a program development grant to get a program off the ground, now they're up and going, and that's where these expansion grants are really important. And we've really, again, I'm saying that we're at an inflection point. What we're seeing is these programs are now maturing, and what we're finding is they still need that bit of money per year per resident to help keep them where they can sustain their programs. So the expansion grants have become a real area of focus for our board. And so this just, we've had 13 feasibility grants that we've granted, 14 program development grants, and now we're up to 41 expansion grants, because a program who's been in existence now 2 or 3 years, they may be in their third cycle of asking for the expansion grants to try and, again, sustain the programs that have started over the past 10 years. And so this just outlines what specialties can qualify for these grants through the GME board. And you can see they're basically the primary care specialties plus some specialties of high needs in multiple communities. So psychiatry, general surgery, emergency medicine, OB, as well as family medicine, internal medicine, and pediatrics. And then you can see that the amount that we've had available has been going up over time, but we're now sort of at a plateau in that, and that's really one of the challenges, and I'll talk more about that. And then here are the different specialties that have received the various grants, again, either discovery grants, program development grants, or expansion grants. And you can see that's primarily internal medicine, family medicine, psychiatry, although we've also had general surgery, emergency medicine, OB, and then some of the feasibility grants are the ones that have multiple specialties listed there. And so it gives you a sense of the mix of different specialties that have been, that have been stimulated through this grant process. And so a little less than $1 million of the funding has gone towards feasibility studies, 6.75 million into development grants. And then again, the residency expansion grants are where the majority of this have gone. And we're up to almost 35 million now that have gone towards residency expansion grants. And I do want to point out that specifically for family medicine residency programs in the state, for 20 years or more, we've had a separate medical education board that is it's a carve out specifically for family medicine. And this is not a really to go towards salaries of residents or even salaries of faculty. This money is available for family medicine residencies to apply on an annual basis for grants that allow them to do some special projects. A lot of them have used this for point of care ultrasound curriculum support, or other simulation models, those sorts of things. But there is a smaller grant opportunity there specific for family medicine residencies. And I wanted to point that out because that's been very helpful specifically for family medicine. And so looking at the progress, what are our results? 10 years into this, over $40 million have been awarded in grants, over 260 new positions have been funded, and that's really been awarded to a wide variety of hospitals and consortium throughout the state of Indiana. And again, you can see the list on the side there of programs that are currently in development and expansion. Again, psychiatry, family medicine, internal medicine, recently general surgery, OB, psychiatry is in the works. Those are all in Fort Wayne, which prior to all this had one family medicine residency, and now they'll have two family medicine residencies and these others. And Fort Wayne's the second largest city in Indiana, so it's interesting that they're just really, again, outside of Indianapolis, there hadn't been a lot of GME in Indiana until this last 10 years. One of the things that the board did was enlist Trip Umbach as a consultant and helped us develop a financial impact study looking at what this money that the state was investing, what was that resulting in? And based on the number of new positions that had been created, looking around the state and what that means by adding those GME programs within the various communities around the state, Trip Umbach in 2022 provided this information where they estimated that return on a dollar invested by the state had an $8 return per dollar invested by the state, and at this point, more around $12 in 2025. And we used this data when we went to the state in the budget cycle in 2023 to ask for an increase in the amount of annual appropriations, and we were successful in increasing it at that point from $5 million a year to $7 million per year. So that's what we've had as a board the last 2 years. The last 2 fiscal years to work with has been $7 million per year. And so that's been great because what we've seen every budget cycle up until now has been an increase in the amount that the state's been willing to fund. So in academic year or fiscal year in the state, 2024, 2025, we've again sort of hit this inflection point where we've got now more requests for grants than we've got money available to fund. And so really for the first 10 years that the board was in existence, any legitimate applicants coming for a grant request have been able to be funded. And so now we have sort of switched into where we have to look at this as a competitive awards program from the standpoint of we've got to determine what are the criteria that help us prioritize where this money is going to be going, because in this current year that we're just finishing up, we had $7 million appropriated from the state, and we had $10 million in requests. And so what we had to do this year was we prioritized those feasibility discovery grants and the program development grants. But when it came to the expansion grants this year, we were able to give every requester a sum award, but no one received all of the expansion grant award requested. And so that's unfortunate. It's making us start to worry about then sustainability from that standpoint. And so I've got a couple of graphics here just to explain sort of why we're at this inflection point now. So you can see the first few years that the state was appropriating into this fund, we had appropriations, but we weren't spending any money because at that point, the hospitals weren't aware. The word hadn't really gotten out. People weren't sure whether they want to get into GME or not. And so we really didn't spend any money those first couple of fiscal years that we had money appropriated. And so we were able to bank that money. And it rolled over to the next year. And then you can see over the last 5 years, especially now, that we've really ramped up the amount that we've spent because we've had many more requests as hospitals around the state have seen the success of the strategy of developing GME and what that means to their communities. And so you can see that appropriations versus expenses has been ramping up. And then on this slide, the orange is how much then was in the balance of the fund. So again, those first 2 years, we were getting 3 million per year, but didn't spend any those first couple of years. So by the end of the second year, we had 6 million built up. And you can see then that each year we were actually banking a little more than we were spending. But again, over the past 5 years now, as the grants applications have ramped up and we've spent that money appropriately, and very, this shows the success of this program. Now we're at a point where, unfortunately, we're having to spend, there's more requests than we have money available is the bottom line. And so, moving forward, a goal when all of this started was to create additional 500 residency slots in the state. And so that dark blue bar there shows really what our current appropriation has been. And we get appropriation on a 2-year cycle, on a biennium. So the last biennium, we had 14 million, so basically 7 million a year in the last biennium. To maintain the current progress and to be able to fund through those expansion grants the number of new positions that have been created, we really would need close to twice that. We need about 14 million per year now, or 28 million over the biennium. And we project that at full maturity, we will need somewhere north of 35 million per year, or a little more than $70 million per biennium, to be able to continue to sustain this with what the state has funded to this point. Here's our big challenge. So the 2025 is a budget session for our legislature. Our legislature meets the first 4 months of the year in the budget years. So this year they met in January, February, March, April. And so April 25th was the last day of the session. And on April 16th, they got a new state forecast and updated the financial forecast from the December 2024 forecast, and it projected 2 billion less in state revenue than had been projected in December of 2024 going into the legislative session. And so I think this is a very descriptive photo right here. The man on the far right is Representative Thompson, and he chairs the House Finance. And then the man in the middle there is Senator Mishler, who chairs the Senate Finance. And you can see the gravity on both of their faces as all of a sudden there was 2 billion less to spend. And so in the last week of the session, they had to cut $2 billion from our state budget for the next biennium. And so the good news is our GME board has continued to be funded at the 7 million annually, or 14 million in the biennium that we had in the previous biennium. Although the bad news on that is, again, we're now at a point where we really need about 14 million annually to sustain the growth we've achieved. And so the good news is they didn't totally cut it. In fact, they maintained where we were at. So that is good news. But we're now faced at the GME board for, again, looking at how do we prioritize at this point then new grant applications when we award that. And so here are the criteria that we're using. We look at underserved location, and this is based on Robert Wood Johnson Foundation data, rural location, also from Robert Wood Johnson Foundation. So you can see about 40%, 40 points are based on that. And then the collaborative approach of the GME program, the age of the program. So if it's a brand new first year program, it gets a full 25 points. Second year, it gets 20 points. Third year, 15, and on down. And so once it's 5 years old, there's no points for the age of the program. And then strength of application, which really is looking at the degree of support from both medical staff, administration, administrative match basically from the sponsoring institution as far as what they're willing to fund. Some community support is mixed into there, as well as then looking at the plans for developing and supporting the program long term. So that's the criteria that the board has landed on. As we go into this next cycle, we'll be utilizing this rubric to try and determine the prioritization of use of this. But our real ongoing challenge in Indiana, and why we can't let this slip, is that we, for several reasons, but probably the main reason is for 100 years, we only had one medical school in Indiana, and we had enough GME slots to support one medical school. But when we compare ourselves to our neighbors, we are way behind on GME training programs and number of residents. And then when you adjust that by population, it looks even worse. So, Indiana is on the far right there. So we have just over 20 residents per 100,000 population in the state. When you compare us to the United States as a whole, we're at about half of what the United States is at. And when you compare us to our neighbors in Michigan, Ohio, and Illinois, we're at a third or almost a quarter of what other states around us have as far as the number of residency slots per 100,000. In fact, we rank number 46 in the country for this. And so, this is the kind of compelling data we are trying to utilize with our legislature. We spent a lot of time in this last budget session making the case for why we needed to increase the funding. We got a lot of thumbs up and a lot of support. And again, the communities where these GME programs are being developed, we have representatives from all over the state who see that value. But unfortunately, in that last week of the session, there was a lot of cold feet around increasing the funding. But again, at least we didn't have the funding totally pulled out from under us. And this is just another example of what data we utilize when we're talking to our legislators. Is Indiana is number 7 in the country for utilization of emergency room. And this is really just, again, an example of the downstream effect of not having enough primary care physicians in the state, and why we need to be working on that. And then this is information that we also look at as not just training in Indiana, but also then what do we do to retain? Because what we've seen is a decrease in the percent of our physicians completing family medicine residency in Indiana that stay in Indiana. And we think that that's because in Indiana, they can get up to about $80,000 in loan repayment, whereas they go across the border into Michigan and they get up to $300,000, or across the border into Ohio and 120,000. So we've got to look at not just GME growth, but also what are our incentives for retaining physicians in Indiana. And we're fortunate in Indiana, we have the Bowen Center through the Indiana University School of Medicine. And the Bowen Center does a lot of workforce tracking. And so I encourage you, if you're interested to see what sort of information you could get at the state level, if you had that sort of resource in your state, I encourage you to look at this at the bowenportal.org. Some really interesting healthcare workforce, not just physician, but healthcare workforce tracking. And so if you don't have that in your state, that would be something to consider, because that also can help make your case for state funding. So we see our opportunities as continuing to have a coalition advancing the advocacy for GME. And I've mentioned some of these, but also in the last couple of years, the Indiana Business Health Collaborative has been formed, looking at how do they decrease the cost of healthcare in Indiana, specifically because the Indiana's employers have a higher cost per employee than many other states, and we see that as an economic drain and a barrier to business growth in Indiana. And so that's a new group that has jumped in the last year that's been very active in this. And then what we need to do, an opportunity we have, is to really track then the retention results from what this GME funding has achieved over the past 10 years. In Indiana, a high priority is addressing OB deserts in rural Indiana. And so, really trying to look at specifically how can we find opportunities in the GME community to bring together the OB residencies, family medicine residencies. Right now, we only have 2 family medicine OB fellowship positions. We believe that that growth there would be very important. And then how do we work with our nurse midwife colleagues in the space of prenatal care and delivery, especially in rural areas, and develop a hub and spoke approach there. And then here at Marion, at the College of Osteopathic Medicine, we are pursuing AACOM sponsoring institution accreditation. I hope to have that by the end of this calendar year and be able to then approach hospitals that otherwise might be intimidated by the lift of becoming a sponsoring institution and be able to more quickly partner with those hospitals to look at supporting the development of new programs. So what can you do in your state? If you're trying to figure out that, the first thing you do is get your data, work through the Bureau of Health Workforce, through HRSA, look at the AAMC data, work with your state Department of Health. We have a task force right now in Indiana that's looking specifically at primary care physician workforce. And so, that's a great ally to have as we're approaching the legislature for appropriations, is to have the state supporting us. And then the National Governors Association has a nice toolkit on their website that can help you look at health workforce as well. And then, once you know what your workforce data is, look at your training data. How many residents, where do you stack up nationally as far as the number of residents that you're training per population? And then figure out who cares about this, who wants to see more GME in Indiana to address, or in your state to address your healthcare workforce, and look at the business coalition, your chambers of commerce in various communities, hospitals and health systems, your medical schools, your legislative leaders, especially those that have a connection to healthcare in some way, or have a connection to the business community, because again, often they recognize that healthcare expenditures are a drain on the business community, and by trying to address that through improving access to care and improving health outcomes is a good investment. And then patient advocacy groups. I think we overlook these sometimes because it can be very powerful. It feels self-serving, or it can appear self-serving when an assistant dean of GME is saying we need more GME funding. That sounds really self-serving. But when we work with patient advocacy groups, and they can advocate for increasing the investment in GME, that can make more of an impression. And then look at your state Medicaid department, your Department of Health, your Commission on Higher Education, and see who within there you can get really motivated around this. Build your coalition, develop your blueprint, and then look at the resources needed, including funding. In Indiana, what we're trying to do is we've never gone for any federal matching funds. And right now, because of the uncertainties in DC, there's some hesitation at the state level to look at federal matching funds, but it feels like that's a missed opportunity if we aren't leveraging what the state's already investing to get some matching federal funds. And then we need to, we're going to be utilizing this rubric. And we may need to refine that even more based on the needs of individual programs. For example, one of the programs that started over the last few years is a psychiatry program, 4 positions per year, so 16 residents, and they get the $45,000 per resident. So they've been getting $1 million a year, and this is a rural hospital that if they lose their $1 million a year, all of a sudden this great program that's been developed is really at risk of being sustained. And then looking at health systems and private investors as well. And then we always have to be working on advocating at the federal level for more support. So happy to, there's my email address, and go Pacers. We start in the NBA Finals tomorrow night, and happy to answer any questions. I see there's a few in the question answer. So impact of HPSA scores on funding. Well, I think again, I shared that rubric, and what we're looking at is rural location as well as workforce, healthcare workforce shortage areas as part of our priority. Does our ROI show how many new doctors you have in the state and in the specialties needed? No, at this point, we haven't really tracked that as much as we need to be. And so that's a next step for us. And we've talked with the Bowen Center and with our State Department of Health about really doing a better job of tracking now from those new programs. But most of those new programs, again, are just in their third, fourth year. So we don't have a lot of data yet for where those physicians are landing. And a question was, what are the predictors for return on investment estimation? And I think that's, looking at some of the data that's been out there about what's the impact of a primary care physician on a community. And then specifically around GME, there's been some work that has shown that by adding a GME program based on, employing more focus, if you add a program in a community, you are employing people as well as improving health outcomes, making access to care better. And so that's where some of that return on investment shows up in improving health outcomes and the economic stimulation in the communities where those dollars are being invested. Have we had a problem with insurance pulling back jobs for new graduates favoring CRNPs? So I don't think we've really seen that, especially in primary care, that there aren't jobs for primary care physicians when they're finishing residency. In fact, every hospital we talk to about starting new programs, that's the thing they lead with, is they would like to be recruiting more. In fact, one hospital looked at their service area and they estimated they could they had the capacity for 28 additional primary care physicians in their service area. So we've not seen that. And really the OB deserts in Indiana is more related to, especially in rural areas, one person can't do this alone. So it's not like you can recruit one person into a community who can do C-sections and expect them to be able to cover 365. And so you've got to put teams together, and that's where we've seen rural hospitals that maybe don't have high volumes of OB services, and so then they can't afford to hire 2 or 3 physicians to cover the lower volumes. And that's where this hub and spoke idea may help with developing teams that can then sort of have a little more ability to cover especially prenatal care in rural areas. So those are the questions that I've gotten so far in the
I appreciate it. I think our time is just about up. I'd like to thank you for being with us. This was a lot of information. We appreciate you and your willingness to help us with all this. We in Arkansas are just now developing our graduate medical education board. We're a few years behind, but we're getting there. But thank you for your expertise. Thank you for everyone who joined us. This concludes our webinar. Thank you again, and have a great evening.